Contrast induced nephropathy. How to prevent? Before going into the preventive step, two parameters you should know. What is the indication of that particular contrast study? Contrast, here we are discussing related to the contrast CT, not contrast MRI. First we will discuss regarding contrast CT. Why that investigation is planned? Is it very important, or it can be, or that modality of the investigation can be non-contrast and we can find the diagnosis? Let me give an example. For renal stone disease, even NCCT KUV is enough. No need for the contrast CT. So first, what thing you have to assess is why the CT is planned. Is it very important, or any other modality can be used or not? This is the first one you have to assess. Second, the risk patient. Who are all at risk of contrast induced nephropathy? Old age patient, age more than 60, diabetic patient, eGFR less than 60, it itself a risk, less than 30, the patient is at high risk. Old age, diabetes, it itself makes the patient bit prone. Once the eGFR is on the lower side, the risk increases. Less than 30, it have to be very, very careful. Any patient on nephrotoxic drug, any patient who recently recovered from AKI. These are all the important risk factors. Apart from this, uncontrolled diabetes, uncontrolled hypertension, diabetic history, uncontrolled, both are the risk factor. Between these two, first assess the case, then decide. Okay, we have come to the conclusion that patient need contrast study and the patient is at bit risk of contrast induced nephropathy. So to prevent it, the most important first step is the patient to be euvolemic on the day of CT. A CT can be done in the emergency situation and in the elective situation. We are discussing about the elective situation. Patient have to be euvolemic. If patient is hypovolemic, the risk increases proportionately. So make sure patient is euvolemic. This is the first step to prevent contrast induced nephropathy. Second, before the contrast and after the contrast, give adequate hydration. Normal saline can be preferred. If not, ringer lactate can also be given. Normal saline on an average of 100 ml per hour for 6 to 12 hours. After the procedure, up to 18 hours. Adequate hydration to be given. Whenever we say adequate hydration, what is the important parameter is how good is the cardiovascular system to accommodate the fluid. So second is the normal saline or adequate hydration before and after the procedure. What is the advantage of that? The kidney will flush it out. The contrast will be flushed out outside. Okay. Theoretically, it is 1 ml per kg per hour for 6 hours before the procedure. After that, 1 ml per kg per hour for 18 hours. This is the theoretical protocol. But practically, patient can take oral hydration also. And if patient is at highest risk, IV hydration is preferred. So third one, the type of contrast. Use isoosmolar, means approximately there are 3 type of osmolar agent, that contrast having 3 type of osmolarity: low, isoosmolar, low osmolar and high osmolar. Either use a isoosmolar one, which will be difficult to get, where the osmolarity is similar to the patient's blood osmolarity. Suppose if it is not available, use low osmolar contrast agent. Low osmolar CT contrast agent have to be used. The volume of contrast, ideally 1 ml per kg might be required for the contrast studies. Whatever the amount of contrast for that particular study, you can discuss with the radiologist, then you can use, rather than the general protocol for any other patient. If the patient is at risk, use a patient specified dose. Use the lowest dose possible, whether it is angiography, whether it's a particular renal angio or renal urography, or it is brain related, or it is chest related, wherever it is required, accordingly the dose protocol have to be. use the dose adjustment protocol to prevent it. And the another one, based on the patient profile, we have to stop the drugs which can precipitate the AKI. What are those important drugs? Metformin, AC inhibitor, sometimes dapagliflozin. Sometimes, if the patient is at risk, better to avoid these drugs. Metformin, AC inhibitor, ARB, better to stop 3 to 4 days before and restart it after 1 day. These are all the cases when the eGFR is pretty low, less than 45 to 30. These are individual decisions. But metformin, AC inhibitor, better to avoid. Dapagliflozin is an individual decision because these causes creatinine fluctuation. Already the patient is at 1 nephro, sometimes cause toxicity, not always. These are nephroprotective drugs. Some medicine student will ask, sir, Telma, enalapril, these are nephroprotective. How come it became nephrotoxic here? Those are nephrosafe in the long run. But in acute situations, sometimes it causes nephrotoxicity because of the renal hemodynamic adjustment. If this is also there and AC inhibitor ARB given, it can cause nephrotoxicity combined together. As the eGFR is below 45 and that if it is above, no need to stop. We have to stop certain drugs based on the patient profile. And next one, what are the other drugs? N-acetylcysteine, soda bicarb, these are all the drugs which can be used on the individual patient-centric decision based. There is no clear-cut guideline which says this have to be used, but this can be considered. N-acetylcysteine and soda bicarb replacement, even though the proof or evidence for these are yet lacking. Small studies are there which shows this. But for a medicine resident, you should be aware of this. So for contrast-induced nephropathy prevention, these are all the steps. These are all the 2 important parameters you should be aware. Why the study is planned? What is the risk factor? Make sure patient is euvolemic. Give a good amount of hydration. Use a low dose of osmolar agent or low osmolar agent or isoosmolar. And low dose, patient-centric dose. Stop any nephrotoxic drug. N-acetylcysteine and soda bicarbonate can be used as per the individual decision. So for the students who are working in the ward, MD residents who are working in the ward, so make sure these are the things you are checking before sending the patient for the contrast study. Because once the contrast-induced nephropathy set in, it will be difficult to manage in the initial times. If it is severe, they can land in dialysis requiring AKI also. And as the GFR is more than 60, unlikely for the patient to develop this unless there are risk factors are there. Out of this, which is the most important one? Euvolemic status and the hydration. Even better to avoid diuretic also in these situations. Any doubt related to this, comment below. In the next topic, we will see. Bye-bye.